This is part of a series I call the Making Evidence-Based Medicine Simple series, or MESS for short. In MESS Minis, we review an essential EBM concept. In this MESS Mini, we will discuss how to use diagnostic testing thresholds in the clinical decision-making process. At the completion of this presentation, you will be able to determine the impact of decision thresholds on testing and treatment options, and understand the relationship between pretest probability and diagnostic test results. There are a number of aspects of the diagnostic process that can be studied. These include studies of differential diagnosis, diagnostic testing, and clinical decision rules. Studies of diagnostic tests can focus on a variety of aspects of tests, such as the properties, precision, accuracy, impact, and prognostic implications. We will focus today on studies of diagnostic test accuracy. This slide illustrates the probabilistic or type 2 thinking approach to diagnosis. This is in contrast to the intuitive pattern recognition or type 1 thinking approach that is high risk of bias and prone to error. We start by generating a list of likely diagnoses and estimating the relative probability of each. We often prioritize this list by organizing them to those that are common and those that are life-threatening. We then conduct investigations in an iterative fashion to increase or decrease the probability of each diagnosis on the list and adding or removing diagnoses from the list. These investigations may include elements of the history, physical exam, and diagnostic tests such as imaging or laboratory tests. Finally, we identify the most likely diagnosis. Essentially, we use diagnostic tests with a positive and negative outcome to allow us to stratify the patient into high and low risk groups. The test characteristics, sensitivity, specificities, predictive values, and likelihood ratios help to assess how well the diagnostic test accomplishes this risk stratification. Testing and treatment thresholds assist in determining the clinical implications of test results. Before we can talk about interpreting the results of diagnostic tests, it is important to understand how we use diagnostic tests in the clinical decision-making process. We typically assign a disease probability to a patient based on a chief complaint, history, and physical exam, and sometimes basic labs. Epidemiologic studies, clinical decision rules, and scoring systems such as the Wells score for pulmonary embolism can be used to further define disease pretest probability. We typically set a threshold for disease probability that would not require further investigation. Patients below this probability of disease would not require further diagnostic testing. The disease probability below which we would not need further testing is called the testing threshold. Below the testing threshold, there is such a low probability of disease that the patient requires no further testing and no treatment. For example, a patient with vomiting and diarrhea with no abdominal pain or tenderness would have a very low probability of appendicitis and would not require additional testing for appendicitis. There is a disease probability above which you would treat the patient for the disease and not require further testing. This is called the treatment threshold. Above the treatment threshold, you would treat the disease without need for further testing. For example, a patient with an area of cutaneous erythema, induration, and tenderness with a large area of fluctuance could forego a point-of-care ultrasound and undergo abscess, incision, and drainage. Where do these testing and treatment thresholds come from? The thresholds can be calculated using the properties of the test, including its safety, cost, and acceptability, the nature of the treatment, including its effectiveness, costs, and risks associated with its use, and the disease prognosis both with and without treatment. These parameters may not be specifically known and may require considerable judgment. The patient's values of the costs and benefits involved also need to be included in the analysis. Even without explicitly calculating these thresholds, we use them intuitively on our clinical decision-making. For a disease probability that falls between the testing and treatment thresholds, we can typically utilize diagnostic tests to help us stratify the risk of the disease. For example, a patient with an area of cutaneous erythema, induration, and tenderness with a questionable area of fluctuance can undergo a point-of-care ultrasound to determine whether there is a cellulitis, which requires only antibiotics, or an abscess, which requires incision and drainage. Between the testing threshold and treatment threshold is the testing zone. A good test will put you below your testing threshold when the test is negative, and above the treatment threshold when the test is positive. A poor test would leave you between the thresholds with both a negative and positive test result and would require further testing. Most tests are better in one direction than the other, and how well they perform will depend on the patient's pretest probability of disease. In this example, we have a pretest probability that is close to the testing threshold. If the pretest probability is close to the testing threshold, then a negative test is likely to put you below the testing threshold. If the pretest probability is close to the testing threshold, then a positive test may not put you above the treatment threshold. For example, in a patient with a very low probability of pulmonary embolism can be ruled out with a negative D-dimer. The same patient with a positive D-dimer will require further testing in the form of a chest CT to rule in a pulmonary embolism. In this example, we have a pretest probability that is close to the treatment threshold. If the pretest probability is close to the treatment threshold, a positive test is more likely to put you above the treatment threshold, while a negative test may not put you below the testing threshold. For example, in a patient with a high probability of pulmonary embolism, a pulmonary embolism cannot be ruled out with a negative D-dimer, and we need a chest CT to rule out PE. In general, testing is helpful when there is agreement between the pretest probability of disease and the test result. For example, a negative test is helpful in a patient with a low pretest probability of disease, and a positive test is helpful in a patient with a high pretest probability of disease. Decision making is made more difficult when there is discordance between the test result and the patient's pretest probability. This is the likelihood ratio nomogram that calculates the post-test probability of disease given the patient's pretest probability of disease and the likelihood ratio for a positive and negative test. We have set our testing threshold at 2% and our treatment threshold at 95%. Once the post-test probability of disease is known for each test result, they can be compared to the testing and treatment thresholds. In this example, we start with a patient with a low pretest probability of 5%. For our patient with a pretest probability of 5%, a positive test does not put us above the treatment threshold, and a negative test puts us below the testing threshold. In other words, at a low pretest probability of disease, the test is not helpful in clinical decision-making if it is positive, and is helpful in clinical decision-making when it is negative. This patient has a moderate pretest probability of 20%. A positive test puts us above the treatment threshold, and the negative test puts us below the testing threshold. In other words, the test is helpful, that is, it will influence clinical decision-making both when it is positive and when it is negative. The last patient has a high pretest probability of 50%. For a patient with a pretest probability of 50%, a positive test puts us above the treatment threshold, but a negative test does not put us below our testing threshold. In other words, a positive test is helpful in clinical decision-making, but a negative test is not helpful in clinical decision-making. We have determined the post-test probability of disease for patients with a low 5%, moderate 20%, and high 50% pretest probability. Given a pretest probability of disease, we can use the likelihood ratios for a positive and negative test to determine the post-test probability of disease. We can then compare the post-test probability of disease to our testing and treatment thresholds. This example illustrates that the post-test probability of disease and the clinical usefulness of the test will depend on both the pretest probability of disease and the likelihood ratios. In summary, a diagnostic test can't affect your management strategy if you don't have a management strategy to begin with. A strategy requires an understanding of the pretest probability of the patient, test characteristics, and particularly the likelihood ratios, and testing and treatment thresholds for the disease. It is important to determine what you will do with both a positive and negative test results before you order the test. There are related MESS minis that review other aspects of the diagnostic testing process. These include MESS minis on diagnostic test characteristics, likelihood ratios, and receiver operating characteristic curves.